Good afternoon, and thank you for joining us today. We are excited to welcome Dr. Michael Brisman from NSPC Brain and Spine Surgery, who's going to talk to us about acoustic neuroma. He's going to talk to us about some different treatment options, as well as issues and symptoms that AN patients deal with following treatment as well. We're glad you could join us on this Giving Tuesday. We've been celebrating all day long, celebrating our volunteers, active on social media, and we hope that you've seen some of our posts. Dr. Brisman, welcome. I think I'm going to let you go ahead and introduce yourself and tell us a little bit about yourself, and then go ahead with your presentation, and then we'll do a Q&A after your presentation and answer patient questions, as many as we can.
Thank you so much. So thank you so much for having me. I am Dr. Michael Brisman. I'm a neurosurgeon. I've been involved in neurosurgery my whole life. My father was a neurosurgeon. He worked at Columbia in the city, in New York City, and I became a neurosurgeon, and my brother also became a neurosurgeon, and he works with me as well. I've been in practice on Long Island for 22 years now. I trained at Columbia for medical school, then at Mount Sinai for my residency. And we saw a lot of acoustic neuroma patients, and they all got open surgery, craniotomies, open surgery. And I've been in practice now for 22 years, and I specialize in brain tumor and trigeminal neuralgia, and I basically elective brain treatments, and I treat a lot of people, including a lot of acoustic neuroma patients. I mean, I don't know the exact number, maybe it's about 200. I'm sure that people have treated more than I have, but I do have a lot of experience with it. And I wanted to share with you my thoughts and my perspectives. I've been the director of the Long Island Gamma Knife. A Gamma Knife we opened 18 years ago at a hospital that's now called Mount Sinai, South Nassau. And I was also head of neurosurgery for many years at another hospital in the area that is now, called NYU Winthrop Hospital. I'm the head of our group, which is like 21 neurosurgeons, one of the biggest private neurosurgery groups in the country. And one of the advantages of being in a big group is it gives you the ability to super specialize. So I have other guys doing spine operations and other things, but I'm able to super specialize in facial pain and brain tumors for the most part. But all right, so I'll just go through my slideshow. Acoustic neuroma is also known as vestibular schwannoma. It's a benign tumor that arises from the 8th cranial nerve. The 8th cranial nerve is involved in hearing and balance, and it tends to specifically arise from the balance nerve, the vestibular nerve, so not really the acoustic nerve, and it tends to really be a tumor of the Schwann cells, the covering cells of the nerve, rather than the nerve cells themselves. So technically, it's really a vestibular schwannoma, but we all call them acoustic neuromas, and that's fine too. And it's understood what we're talking about. If you look on this picture here, well, on the left is a picture of a large, the white blob there is a big acoustic neuroma, and it's in the pressing on the brain in the back part of the brain called the pons and the cerebellum. Let me just see if I have arrow. Oh, here. So this is the tumor. This is the brainstem here, the pons. This is the cerebellum. So it's usually said to be in the cerebellopontine angle because it's in the angle between the cerebellum and the pons. This is it. One second. This is an example of if you were looking inside the skull, you would see deep pointing towards from the ear inward is where these tumors lie, and they tend to arise from this space within the canal where the 7th and 8th nerve run, the nerve that's involved in hearing and balance, and the facial nerve involved in facial movement. And it arises from that canal, then can grow into this area here and can become very big and press into the brainstem and cerebellum, although often it does not. So symptoms at presentation can include decreased hearing is one of the most common, tinnitus or ringing in the ear, problems with balance. Those are certainly the most common. Headaches and facial numbness are less common. Again, the presentation now, because we have an MRI now on every block, we usually pick these up pretty quickly, and they're usually found pretty early. So in the past, I mean, people might have had to have an awful lot of symptoms. We would find them when they were very big, and there wasn't much imaging. Now they're found very small, in fact, often tiny. So sometimes we'll find them when they're the size of a bead. But usually the presentation is decreased hearing in that ear and maybe some ringing in the ear. Other symptoms are a lot less likely, but not impossible. The diagnosis is with an MRI of the brain with and without gadolinium, or with and without contrast. The MRI involves no radiation, is very safe. In fact, the only issue with gadolinium is in a person who has like kidney failure or on dialysis, but otherwise this would be the test of choice, and we would be able to see the abnormality very clearly. And almost always we can tell for certain that this is an acoustic neuroma just based on the imaging alone. It's usually not a question as to what is it. I mean, every once in a while there's some uncertainty, but almost always we can tell from the imaging alone. The diagnosis is made by different people, and the different people who might be involved, including your family practice doctor, your internist, your neurologist, the ENT doctors, the neurosurgeons, audiologists. But a diagnosis nowadays is often made pretty early on, and when the tumor is on the smaller side. Again, it's rare that we see tumors, that are really enormous when we first discover them, at least in this country, and that's a good thing. The natural history is these tumors grow, but they can grow very slowly. Some can become quite big, but often they can go many years without showing any change, or when they do change, they grow very, very slowly. And often hearing does tend to decrease in that ear. It can be gradual or it can be sudden. Sometimes a person suddenly has a drop off of hearing. Sometimes there can be improvement over time or with some steroids, but often the hearing can just decline and not come back. So it can vary, and it's unpredictable. How will that progress? Will it go away this year? Will it stick around for 5 years before declining? How fast will it go? We don't really know. Treatment options include observing it, and by observing it, that means, following the patient, their symptoms, and MRIs. It can include open surgery, which means we make an incision in the head, we drill some bone, and then with a microscope remove some tumor, or this radiosurgery where we use super focused radiation to sort of zap the tumor and stop the tumor from growing and shrink the tumor without really cutting into the head at all. And one of the things I'm going to emphasize in this talk is, I think, we're going to talk about complications and treatments of symptoms, but I do think that the choice of treatment is pretty critical in avoiding the complications and getting the optimum results. And I would put my results up against anybody, even people who've done more cases than I have. And I think it's not because I have, better dexterity, but it's because I think I make a good choice, and I'll share that with you about how to treat the patients. So the anatomy, as far as what's going on in there, there's a lot of stuff in there. In that little space, there's a lot of important things. We mentioned the internal auditory canal is where the tumor arises. In there is the 8th nerve, which is involved in hearing and balance, and the 7th nerve, which is involved in moving the face. Within the cerebellopontine angle is the cerebellum, which controls balance, and the pons, the brainstem, which controls everything, movement of the body, sensation of the body, consciousness. The 5th nerve is right nearby and controls feeling in the face. Sometimes patients with acoustic neuromas can get numbness in the face with or without an operation. Sometimes they'll get trigeminal neuralgia, where they get sharp pains in the face because the tumor presses, if it's big enough, on the 5th nerve. Then below the tumor is the 9th, 10th, and 11th nerves, which are important for swallowing, for speaking. So and there are important arteries in that area as well, without which one can have important, major strokes or serious things. So the anatomy, there's a lot of important stuff in that area. Just to show differences in acoustic neuromas, on the right is a very, very large acoustic neuroma, the type that's rare to find these days, at least in this country, fortunately. On the left is a very small acoustic neuroma, that's actually much more common, the kind of thing that we see now routinely, smaller acoustic neuromas that isn't even pressing on the brainstem or cerebellum. It hasn't even grown out of the internal auditory canal much at all. These are some medium-sized acoustic neuromas that have grown a little bit outside of the internal auditory canal and are starting to grow towards the cerebellopontine angle. Here's a medium-sized one. Here's a medium-sized one as well. Here are some bigger ones. Again, this is one, again, showing somewhat more growth towards the brainstem and cerebellum. This is an enormous one that's distorting significantly the brainstem. This person probably has symptoms related to brainstem compression. Also, the fourth ventricle, the drainage space where the brain fluid drains, can be pinched down here at the bottom or over here. Over here, you see it's wide open. If that area gets pressed on, people can develop a buildup of fluid in the brain called hydrocephalus that can cause somnolence or even death, and can require drainage of fluid with something called a shunt, a tube that goes from the head to the belly. So surgical approaches, there are three general types. One, the bottom one is for very tiny tumors where we go sort of above the ear and come from the top down. That's hardly ever used now because it would only be used for very tiny tumors, and most of those tumors are going to be treated with focused radiation. The other types can be used, the suboccipital retrosigmoid is used mostly by neurosurgeons, where we go behind the vein, behind the ear, and the translabyrinthine presigmoid is also an operation behind the ear, but you're going in front of the sigmoid sinus, a vein, and you're going through the translabyrinthine, through the bone that is involved in hearing. So necessarily hearing is lost for this procedure. This is just to show the standard neurosurgical approach where we make an incision behind the ear. The sigmoid sinus, the vein is here. We're going to open there's an incision. The bone opening is here. Next, the dura here, the parchment-like opening over the brain is open. This is the cerebellum, the brain. Some fluid is released from down here. We open up, and then we come in here. And again, nowadays, I think this is an operation that should only be done for enormous tumors. This is part of my philosophy. But you see what's going on in here. Here's the tumor. Here's the tumor. Here's the fifth nerve involved in hearing, which if injured can cause numbness in the face or pain in the face. Here's the 9th, 10th, and 11th nerves. If those are injured, there could be swallowing issues, pneumonias. There are important veins and arteries over here. Here's the tumor. Sometimes in the past, people have drilled, this is the internal auditory canal. One has to drill the bone to get in here. And again, one can start removing this tumor and ultimately peeling it off the 7th and 8th nerves and or the brainstem, which have a lot of risk to them. This is just showing the normal anatomy, just so you see there's a lot of important stuff in here. And this is just showing the ICA is anterior inferior cerebellar artery, the pica, the posterior inferior cerebellar artery. These are the arteries that supply the brainstem and the cerebellum. And if they should be injured during surgery, there'll be serious stroke and consequences. This is one of the more serious or common complications of the open surgery is an injury to the facial nerve, which, by the way, is rarely affected by the tumors in their natural history. But if the facial nerve is affected from surgical removing of the tumor, then a person can have facial weakness or paralysis. This is a person who has normal movement to one side, and this side, they can't close the eye, they can't move the face, and it can be very disabling. Risks of the open surgery can include, as we've mentioned, hearing loss, dizziness, balance problems, face weakness, meningitis, chronic headaches, numbness, pain, bleeding, stroke, and death. So it's my philosophy and belief that very few people should go for this open surgery. And I limit it to very, very big tumors. And even when I do that surgery, I only debulk the tumor. I remove most of it, and I do not attempt to take the tumor off the nerves, the arteries, the brainstem, which is where I think most of the complications and side effects come from. Most of the tumors I'm treating with what I call bloodless brain surgery. and I mainly use it, or stereotactic radiosurgery, I mainly use a machine called Gamma Knife. So what is radiosurgery? It's a non-invasive technique that generally delivers a single high dose of very focused dose of radiation to a limited target that's intended to spare the normal nearby tissues and critical structures. This is the machine that I most commonly use, and I would say is the gold standard for acoustic neuroma treatment. I think most patients have been treated this way. I use all the machines, by the way. I use this, I use CyberKnife, I use Novalis, but for my acoustics, I like Gamma Knife. For most of them, it's a one-day treatment. The person is put in a helmet, they lie in this machine, and then once everyone is out of the room, the doors open, the patient's head slides into the machine, and then there are a bunch of these beams inside the machine that are always on. These are emitting gamma rays. It's a type of radiation that all focus on a center point, and that center point we would set at the acoustic neuroma, the benign tumor, such that any individual area of the brain is only getting one beam, so it gets almost no radiation, but the center point gets all the radiation, which is enough to cause the tumor to stop growing and or shrink. Just to show you what Gamma Knife can do, it's not traditional radiation at all. Traditional radiation is really just used for cancerous tumors, and it works because the standard radiation tends to work on tumors, on cells that are in division more than cells that aren't dividing. So cancer cells are dividing actively, so you'll get more injury to cancer cells than you would to a benign cell, but other dividing cells like your hair cells could also be affected. So standard radiation tends to affect cancer cells. You might have hair loss. The super focused radiation works totally different. It's a high dose right on in one or a few sessions right on one area, and therefore can work on cancerous or non-cancerous or normal cells. And it does not cause hair loss. It does not cause fatigue. It does not cause memory changes. It doesn't cause a lot of the side effects of standard radiation that's done over 6 weeks or something. This is an example of Gamma Knife treatment for cancer, for metastases, cancer from the lung that went to the brain. This is a patient I treated who had 3 cancerous tumors. We did a Gamma Knife as the focused radiation. This is where we aim the beams on these 3 tumors. And this was her MRI 6 years later. It was normal. The Gamma Knife treatment eliminated the tumors. It zapped them in one day and freed her from that. And her brain remained normal for many, many years after that. This is a person with a benign tumor called a meningioma. This is a benign tumor arising from the meninges, the covering of the brain. This was a doctor who was 67 who came to me from Manhattan, and everyone there said, why don't we just cut it out? And she said, why don't we not cut it out? Why don't we just do some focused radiation? So because the tumor was a little bigger, I did it with a Novalis machine. We treated over 5 days. And this was years later. The tumor shrank a bit, never bothered her. She did great, and she was very happy. This is an example of another type of benign tumor called a pituitary tumor right here. I had operated on this fellow years earlier. We went through the nose, took out some tumor, and it had recurred. This is the optic nerve. Here's the different image here and here. And we did, so instead of going back, I did Gamma Knife treatment for him. And what you see is several years later, the tumor is completely gone. You would never even know it was there. We didn't need to bring him back to do any more operating. This is another benign abnormality called an arteriovenous malformation, an AVM of the brain. This was a 16-year-old girl who was having some weakness of opposite side, had a complicated abnormality of blood vessels. In the past, we might have tried to operate. These are very bloody, causes lots of problems. The focused radiation I did for her caused those abnormal blood vessels to clot off and disappear. And here's her MRI several years later, and you can't even tell she ever had a blood vascular malformation, and she was cured. And this is an example of someone with trigeminal neuralgia, which can sometimes be caused by acoustic neuromas, where people get these sudden sharp pains in their face, and it's caused usually by a little artery touching on the trigeminal nerve It can be caused also by multiple sclerosis, but here's a picture of the brainstem. Here's the nerve itself. And we found if we injure the nerve a bit, we can get rid of the pain because we disrupt the sensory stimulus to the face. And one way of doing that is with gamma knife. We aim the beams on the nerve. Here's a fellow we treated. Here's the nerve. Here's a side view of the target of the nerve. And then I recently saw him 14 years later, and he's been pain-free ever since. So types of radiosurgery or focused radiation include the gamma knife, which uses gamma rays. There's other machines called LINACs or linear accelerators that use X-rays, which can do the same thing. And those can be used in 1 session or 5 sessions, which is called hypofractionated, because it's less than standard fractionated, which might be a 20 session treatment. And the time I would use a 5 or 20 session treatment is if the tumor is on the bigger side, or if it's close to something very sensitive like the optic nerves. But most time for acoustic neuromas, I'm doing a single session, and usually I use gamma knife. The linear accelerators are good if one has to do a spine treatment or a fractionated treatment or a body treatment. Gamma knife is just for 1 session treatments and just for the brain. So I feel that the gamma knife is the gold standard for most single session brain radiation treatments. And it's what I use, again, most of the time when I'm doing a single session brain treatment. I feel it's the most accurate. It's tightly conformal to the tumor. It's consistent. It has the most data. So when I do a treatment, first of all, we've learned a lot over the years. It used to be people had more problems because we didn't know how exactly were we doing the treatments. We know now that 12 to 13 gray is the right dose. Under 12 gray, you tend not to have as good control of the tumor. And over 13 gray, you start injuring the facial nerve. So if you do that at the sweet spot at 12 to 13, you get outstanding results. And that's something that we now know, and we've known that for many years. If you do it over several sessions, we would do a different dosing regimen. And by the way, so my algorithm, just so you know, for those patients with tumors under 5 millimeters, very small, I leave it alone. Some patients with tumors a little bit bigger, or if they're older, or if it's stable, I might follow it. Almost all the tumors that I'm treating with gamma knife. If I choose a treatment, a surgical treatment, if the tumor is very big, but I still think I can do radiosurgery, I might fractionate it in 5 or 20 sessions with a linear accelerator. And if the tumor is really huge and I feel it has to be operated, I will operate, but I will debulk it. I will remove most of the tumor and leave the remainder that's stuck to all the critical structures for radiosurgery. Here's an example of a woman I treated 18 years ago, one of my first patients. And just to show you, here's the tumor. Here's one of the radiation doses, the 50% isodose line. And then there's the 40 and the 30. But what you're seeing is the radiation trails away very quickly, which is the critical portion, so that the normal brain is hardly getting any. Here's a patient I treated 13 years ago who had some decreased hearing. One of the points of radiosurgery of gamma knife is that there's about a 60 to 70% chance of preserving hearing at the time of treatment. So if we wait till someone has no hearing, we can't save it. But if somebody has useful hearing, then if we do a treatment, there's a very good chance we can save that hearing. And whereas the natural history, they may tend to lose it. So here's a woman who had a smaller tumor. I did a treatment, 13 gray. This was 13 years ago. Here you see the tumor has never changed, stayed the same, and she still has good hearing, preserved hearing. Years later, here's a patient who was about 65 who had a bigger tumor, who I treated with gamma knife also. This was years ago, and this was several years later. What you see is the tumor is completely shrunk away. She still has hearing, it's a little bit less. She never had any serious problems, and she's very happy and did very well. I'll also say that there are a lot of patients who have tumors that either the doctor, if you go to, many of the surgeons don't do gamma knife so much, and they'll say, well, do you want to be stuck with a tumor still in your head? Wouldn't you rather cut it out? But I would say, what difference does it make if there's something in your head? I mean, if it's inactive and not growing, we've got all sorts of things we're walking around with in our head and our body. They'll also sometimes say, well, you want to do radiation, you're going to get cancer. That is not a good argument at all. The chance, and I'm not saying there's no chance of getting cancer from radiation treatments, but let's say it's a handful of patients have had cancer from getting a radiation treatment of acoustic neuroma of hundreds of thousands of patients treated. So maybe there's a tiny risk that 10 years down the road, you might get cancer. I've never seen that happen of hundreds of patients treated. But even if there were an infinitesimal chance, and look, there's a chance of getting cancer from walking outside in the sunlight, you get radiation exposure. The chance of death or problems from the open surgery is at least 1%. It's let's say at least 1 in 100. It's much, much higher than the chance of dying or having a problem from cancer from the gamma knife treatment. So I think that is also a false and inaccurate argument and not reasonable. And by the way, I also offer the gamma knife. I think for young people, there is no concern about this. The radiation treatment is to a tiny area. Here's a young woman who has neurofibromatosis type 2. Now, most patients with acoustic neuromas, it's a spontaneous event. You got it, and no one in your family has it. We don't know why you had it. But some of the patients have it because of a genetic predisposition, because they have a disease called neurofibromatosis type 2, and they have acoustic neuromas on both sides. So this woman was a young woman, 25, had on both sides. She barely had any hearing. We treated this big tumor on the right side with gamma knife. And then we watched the smaller tumor. Years later, the tumor we had treated was almost all gone. Not only did her hearing, was it preserved, but her hearing that she hardly had any on the right ear now is almost normal. She subsequently, we recently did a gamma knife on the other side, and she's doing fine and very nicely. Here's just to show you one of the more recent techniques we also have for preserving hearing with gamma knife is that we will contour out the cochlea, which is internal hearing apparatus, which we use a different sequence, a T2 sequence. And by minimizing the dose to the cochlea, I think that helps us preserve hearing as well. And this is just a gamma knife treatment. These are all my patients, but showing how we're able to treat with a very conformal treatment dose to the tumor. We're able to measure the dose to the cochlea. Now, here's an example of a tumor that I treated, last week. Okay, this was an unusual case that I chose to do open surgery. And again, I believe that there are very few patients that I recommend open surgery. I think it's acceptable, by the way, to operate on everybody. It's acceptable to watch everybody. It's acceptable to do fractionated radiation. I'm just telling you how I do things. I do, again, the very tiny, under 5 millimeters, I watch. If it's a little bit bigger, but it's clearly stable, I watch it. Or they're older, I watch it. Almost all the patients I'm treating, I'm doing with gamma knife, 12 to 13 gray and if hearing is preserved, I keep the mean cochlear dose under 4.2 centimeters, 4.2 gray, preferably under 3.5 gray. And if it's bigger and I still think it can get radiation, I will do it in fractionation. I had, just as a by the way, I had a 70-year-old man, this was like 15 years ago, who had a 4.5 centimeter acoustic neuroma, who presented with hydrocephalus. I shunted him. He was normal afterwards. And he said, you know what, I really don't want a giant operation. Can you do that focused radiation? I said, all right. And we treated him with a 20-session treatment, and he did fine. And years later, he came to me, it was 2.5 centimeters. He did fine. So a lot of the tumors that people think are too big, ask me. I think a lot of them are treatable. This is a patient I just happened to treat last week, so I thought to show it to you. This woman is 75, and just a few months earlier, her tumor was half the size. It showed rapid growth. We weren't sure, was it more aggressive? There was a thought there might have been a bleed into it. So we decided to operate on her. Her tumor was measured at about 4.5 centimeters. There is distortion of the brainstem over here. So this was a pretty big tumor. We decided to operate on it. But the operation that I did, and again, these are my opinions. You're hearing, I'm not saying any other opinion is different. I'm just telling you how I do it. I chose to remove almost all of the tumor, but not all of it. I took out about 95% of the tumor. I did not drill into the canal. I deliberately did not try to peel the tumor off the facial nerve, off the eighth nerve, off the brainstem, off any of the arteries. The surgery only took a few hours, and afterwards, this woman who was 75 was perfect. Her hearing was preserved at the level that it was beforehand. Her face was fine. Everything was fine. She really could have gone home post-operative day 2, but she decided to stay a third day. It was Thanksgiving. For some reason, she wanted to spend Thanksgiving in the hospital. That was her decision, and she went home afterwards. But that's my thoughts about it. So follow-up for patients, we do MRIs, whether they get surgery, radiosurgery, observation. When we do focused radiation, there's often some internal necrosis, a little bit, some death of the inside of the tumor. Sometimes if there's a little swelling, we may use a little steroids briefly. Results of gamma knife have been known for a while. So this is not new or, hey, we're just figuring this out. I'm going to show you 2 studies that have been known for 20 years. The tumor control is outstanding. This is my finding that with the focused radiation, tumor control rate is about 95%. And of those patients that where the tumor still grows, we can either repeat the radiosurgery or operate. Major permanent facial weakness, 0. And I've had the same experience. I've had nobody with facial weakness from the radiosurgery, and the hearing is maintained at outstanding levels. Here's another study, again, showing similar thing. Excellent tumor control. Again, we now know different than what we did 50 years ago. But I mean, with the current dosing, the current treatments, tumor control rates are excellent. Facial weakness is non-existent. Hearing level maintained at very high levels. So I want to tell you my result, just to tell you, so with my algorithm, again, there are people who've treated more tumors than I have. I've treated about 200 acoustic neuromas. I have 0 patients who have died. I have 0 patients who have had strokes. I have 0 patients who have had major complications. I have 0 patients with facial paralysis. I have 1 patient of all the patients I've ever treated who has the most minimal, I operated on him for a very big tumor, the most minimal weakness of his face. And that's it. And most of the patients I've treated still have hearing, if they had hearing when I started to treat them. And again, I do not claim that this is because, my dexterity is better. I've never measured my dexterity against anybody else's, or that my gamma knife is any different than anyone else's. But I do believe that my algorithm, and I think a lot of people are moving over time to the way that I'm talking to you about it. But I think the way that we treat acoustic neuroma has a lot to do with minimizing complications. And the best way to avoid the complications is not to have them in the first place, which I think is critical to how we manage to treat them. So I would say I'm here to help. Anybody ever wants to talk to me, you can talk to me, you can email me, you can have my cell phone. You want to do a remote talk with me, I'm happy to talk to you. You want to show me your films and say, what do you think? I'm happy to tell you what I think. And again, I think there are many different ways of treating people, but I've been very happy with and I think my patients are very happy with the way I've treated things. Now, I'm happy to discuss some of the complications and problems that occur, most of which occur with, I think, aggressive surgical approaches. I have some questions here that other people have asked, or if people want to ask other questions, I'm open to questions and happy to help in any way I can.
Thank you, Dr. Brisman. That was really an informative presentation and gave us a lot of information on the different treatment options, and I appreciate you going through that. We do have a couple of questions from people that submitted them prior to our Facebook Live today, and then I have several questions that have come in while you were talking. So I'll go ahead and start with one who sent in a question early. And this patient is asking about facial paralysis. She had surgery, retrosigmoid, I believe, and had facial paralysis almost immediately following surgery. But her surgeons do feel it's temporary because her facial nerve is intact. So she's wondering how long she should wait before she talks to a facial reanimation specialist or a surgeon to discuss options to restore movement. She also actually has an eye weight and is wondering how you know when that should be removed.
Sure. So first of all, I'm sorry you have the facial weakness, and that's a serious thing, and I'm very hopeful that you're going to get better. Um, Certainly one of our concerns is protecting the eye, because while the eye is not closing, I mean, regardless of what's going to happen to your face and when it's going to happen to your face, we want to protect the eye, because if the eye is not blinking properly, that means dust and stuff can get in, and it can irritate the eye and cause loss of vision. So the gold weight is important. Often people will use artificial tears and see the ophthalmologist. So protecting the eye is a critical component to managing the facial weakness. Second is, it's hard to know for sure, what is the time frame, when is it going to get better? I mean, certainly if the facial nerve is anatomically preserved, that is to say it's structurally intact, there is a real chance it could get better. I mean, I think it's hard to say for sure it's going to get better. When is it going to get better? How fast is it going to get better? Is it going to be 100% getting better? Is it going to be a 92% chance? We don't know that. I think following up with, someone who is going to potentially do a reanimation is reasonable to do from early on. I mean, you could see like the plastic surgeon from early on. You definitely want to give it at least several months, and you may start to see within a few months, even if there isn't full recovery, you may start to see some, excuse me, signs of recovery. Like it may be that, well, in 6 months, it's not all better, but you're starting to see some improvement, and that would be encouraging signs to wait a little more. So the progress in the recovery can take, could certainly take 3 months, 6 months, 9 months, 12 months. And I think while it's recovering, people are going to want to let it recover. But it's never too early to speak to a plastic surgeon or somebody about reanimation. And by the way, they have pretty amazing, awesome methods for reanimation of the face these days. There's a lot of encouraging stuff out there, and I've seen some pretty incredible work. But I think there's nothing wrong with talking to them, immediately, but they're probably going to want to wait at least several months to see if we know that the nerve is physically intact, and there's a good chance it's going to get better.
That makes sense. We have another question about altitude. This person lives in Long Island and goes up to Maine regularly and is wondering if that change in altitude causes some dizziness, because she is experiencing that dizziness only when she's up in Maine. And so I was wondering if you have any insight on that.
Sure. I mean, differences in altitude can cause people to feel differently. So if you go to a different altitude area, you could feel dizziness that may have nothing to do with having an acoustic neuroma. I mean, people do adjust and feel differently when they go to, you go skiing somewhere. I mean, suddenly you're noticing that it's harder to breathe, and there are all sorts of changes, but that is possible. I mean, if you have to go to an area of higher altitude and there is this, dizziness, I mean, and you think it's from the acoustic neuroma, one is the dizziness. Sometimes there are medicines to try for dizziness, like meclizine, that might help. Another consideration might be a Medrol dose pack. A brief course of steroid, if you're going to be there for a brief period, might help. But I mean, even normal people can experience some changes in their feelings of how they feel when they go to high altitude areas.
Okay. And we had a question about X-rays and CT scans. I know you talked about the level of radiation being just not really something that we should consider with radiation treating acoustic neuromas. But what about X-rays and CT scans? Is that something that should be avoided if you have an acoustic neuroma?
So first is, I think X-rays and CT scans have radiation. MRIs don't. So the only time I use any radiation for acoustic neuromas is the time of gamma knife. There's this tiny amount of radiation that goes right to the tumor. Beyond that, I'm using MRIs, which are magnets. So other than the 30 minutes that you're in the machine, I don't use any radiation. I think radiation does need to be considered and minimized, and that includes CAT scans and X-rays. There are reasons to get those. We're particularly concerned about getting them in children, because part of the factoring of radiation effects are how much radiation and the time factor, so how much time elapses. So doing an X-ray in an 80-year-old is less concern than doing X-rays or CAT scans in a 10-year-old. I think if somebody needs to get it, like right after I do brain surgery, I get a CAT scan of the head because that's important. Or getting a single chest X-ray. But some people have suggested getting lots and lots of dental X-rays might slightly increase the chance of an acoustic neuroma. So probably good to, only get a dental X-ray every once in a while when needed. I mean, but you got to take care of your teeth too. So and again, when I follow up on acoustic neuromas, other than the immediate post-operative scan when I'm looking for bleeding, other than that time when I get a CAT scan, I do almost all MRIs. So I think there are reasons to get chest X-rays, CAT scans, but I agree if they can be minimized, they should. And in managing acoustic neuromas, again, the only time I'm giving any radiation is the 30 minutes you're in the Gamma Knife. All other imaging, I use MRIs.
Okay, great. Now we'll go ahead and start with questions that we've gotten during the presentation. We have a gentleman who gave us a lot of information, but I'm going to kind of ask his question a little bit more generally. He is very healthy. He just was diagnosed earlier this year. He has about a 2-centimeter tumor, and there's been no growth with follow-up MRIs. He's not lost any more hearing. He has another MRI coming up later this month. So he's just wondering if there should be worry about missing a window and a period of time before you can do radiosurgery, so that you don't miss that opportunity to treat the tumor before it gets too large to use radiosurgery. Now, based on what you said, that may not be a concern, but that was his question based on what he's heard in the past.
Absolutely. So first of all, the bigger the tumor, the more the concern about radiosurgery. And there does come a point where we're going to say we need to operate, because the tumor is so big. 2 centimeters is certainly well within a range for doing Gamma Knife. I mean, if the tumor got to be 3.5 centimeters, 4 centimeters, we might start to change our mind. I'll also say that the size depends a little bit on the individual and the age. I mean, people's brains shrink as they get older. So a 70-year-old might have a 4-centimeter tumor with minimal symptoms, whereas a 20-year-old might have a 3-centimeter tumor with a lot of mass effect, compression, and a lot of symptoms. So one issue is how big is it for the time of radiosurgery? And again, the smaller, the better. But the other window has to do with hearing. The hearing, we don't know when your hearing is going to be lost or not lost. And it can sometimes go suddenly. So I would say a 2-centimeter tumor, and I'm assuming this is centimeters, not millimeters. A 2 millimeter,
yes,
size of a bead, I would leave that. A 2-centimeter tumor is a moderate sized tumor. And I generally, if somebody comes to me with a 2-centimeter tumor, I would probably just recommend Gamma Knife treatment off the bat. And I think the point would be, one, the bigger it gets, the more risk it becomes. But also, I think that's the best chance of preserving your hearing, assuming you have. If you have no hearing, obviously that's not a concern. So now I would say the exception would be your age. If you told me it's 2 centimeters, we're following it, but I'm 87, I would say, you know what, I agree. And there's a point, by the way, as people get older, like some people come to me, they're 75, they're 80. I kind of believe that as people get older, I start to say, you're 75, you're 80, you get to decide whatever you want to do. The younger a person is, I'm more aggressive, and I'm like, you know what, we should really think about treating this way. Whereas I think as a person gets older, you're allowed more decisions. So if you told me this was just discovered, it's 2 centimeters, you're 85, I would say, you know what, it's okay if you just want to follow it. But if you're younger, and it's 2 centimeters and you have preservable hearing, I would probably have just recommended to do a Gamma Knife treatment now. But if you want to follow it, that's okay. But understanding that at the time of treatment, that's the kind of hearing we can preserve. If you wait till your hearing is 10% or gone, then we should assume that's the best your hearing is going to come out. I mean, now again, there are rare cases where I've done Gamma Knife and people tell me their hearing got better, but that's the exception. Generally, we're hoping to just preserve it at the level it is at the time we treat.
Absolutely. Dr. Brisman, I put your website and number and name and everything in the comments so people can grab it from there. If you want to stop sharing your screen, then people will be able to see your face. I know that's always something with
Sure.
lip reading. It can kind of help. So
hey, there's my face. Well, did anyone see my face before? Was I don't know. All right, here's my
see
face.
it, but it was just a small square.
I
This
see. Now it's a bigger face. Okay.
Yes, yes.
All right.
Okay, so what about tinnitus? And particularly when the nerve is cut during surgery, the hearing nerve is cut during surgery, and tinnitus, becomes an issue. Is there anything that can be done for that?
So tinnitus is a common problem with patients with acoustic neuroma, whether they have treatment or not. The times at surgery that I think it becomes more of an issue is with smaller tumors, because those are patients who have functioning vestibular nerves. So cutting it suddenly may cause some new symptoms all of a sudden, whereas people who have huge tumors and the vestibular nerve was maybe not working at all for years, and they had compensated with the other nerve on the other side, they may not have such symptoms. But I think cutting the vestibular nerve on smaller tumors at surgery can cause a lot of new symptoms, but even patients without surgery can have tinnitus. Tinnitus can be a tough problem to treat. Things that can be considered first is I don't personally, there's no operation that I do. So I'm usually referring people to their ENT doctors or their audiologists, but sometimes people can use hearing aids and it can make a noise that can cancel it out. Sometimes there are other sounds that can be used that can cancel it out, like sleeping at night with a fan on, and sometimes that noise kind of blanks out the noise. Like for example, when I first moved into my home, I realized that I was hearing airplanes at night. So I turned on a fan and now I sleep comfortably and I never hear these airplanes. I think they've since rerouted the airplanes. But the point is that sometimes there are other tricks that can be used that can disable that. Sometimes certain medicines can make it less, and understand also with bothersome and painful things that we experience, there's a co-component of all uncomfortable things that human beings experience that ties in not just to that feeling, but to the feeling that it bothers me, it hurts me, I'm uncomfortable. So your level of stress, your depression or lack thereof, anxiety, all those things can tie into it. So certain medicines might help. Elavil maybe, over-the-counter medicines, but other things like taking a hot bath every morning and every night and turning on your favorite music, de-stressing your life. There are a lot of things that you might find that if I can improve my mood, if I can limit my stress, improve my anxiety, I can treat my tinnitus or my pain. Some patients have, after the surgery, can have bad pain in the back of the head that just doesn't go away. We don't know why that is. Or they can have facial pain because maybe the trigeminal nerve was irritated. And there are medicines we can give, like Elavil is something to consider. And again, I would talk to your ENT and audiologist and pharmacists. They're always coming up with over-the-counter medicines. But again, there's a big picture to these things and trying to see, how do I get my mood improved, maybe with an antidepressant? How do I decrease my stress, my anxiety? If my tinnitus was bothering me at a level of 7, maybe this thing lowers it to a 6, maybe this to a 5, maybe all three together get me to a 3. But that's how I address a lot of chronic pain and problems, and it has to be individualized, but there is hope.
That's great. Okay. You talked a lot about size of tumors and how you treat, and it might not be the typical thing that acoustic neuroma patients are used to hearing, as far as, we usually hear that 3 centimeters is a large tumor, and that is sort of the limit for radiation. But we had a question about that you mentioned you generally only use open surgery for larger tumors. So what do you consider large, and when is that dividing line for you?
Right. So I think it really depends. Now, first of all, when we measure, let's say we're saying 3 centimeters, we're throwing out a number, that can mean a lot of different things, first of all, because are we counting from the internal auditory canal? Like there's a part in the bone that could go for 1.5 centimeters, and then there's the part within the head that could go for 1.5 centimeters. So would you call that a 3 centimeter tumor, or is it really most of the tumor is 1.5 centimeters? When we say 3 centimeters, well, for those of you who, people are aware there's 3 dimensions to things. So how does that measure in the 3 dimensions? I mean, is it 3 centimeters within the brain by 3 centimeters by 3 centimeters? Or sometimes it's 3 centimeters by 1 centimeter by 1 centimeter. The volume matters. You also have to look at what are the symptoms, how much problems, and also the overall picture of that person's brain. I mean, a 25-year-old with a 3 centimeter tumor may have a lot of mass effect shift symptoms and might need to have surgical debulking, whereas a person who's 70, again, I mentioned to you a guy who had a 4.5 centimeter tumor. He did have hydrocephalus, which we treated, but otherwise he was fine. I mean, once we shunted him, he had 0 symptoms. He was like, why are we even talking about an operation? I'm fine. So I think one has to look at, again, a lot of things is not just, is it 3, is it 4, but the size within the cerebellopontine angle, what are the 3 dimensions? What are we counting as the 3 centimeters? What is the size of that person's brain? Well, as you get older, there's a lot of room in there. So what's the size of the brain? So there's a lot of considerations, but I would say that 3 centimeters is not an absolute cutoff at all. And I would say one could, it could be 3.5, could be 4. It depends what you mean. Again, do you mean, is it 4, but you're counting 1.5 centimeters that's inside the bone that really isn't compressing anything? And is it 3.5, 4 by 1 centimeter? Is it more of a pancake? So, and is that in a 70-year-old who has a lot of room? So I think it's a lot of things have to be considered, but I would say, if you want my opinion, send me the films. I'll look, you can send it to my phone. I'll tell you my opinion, but I do think that there's a lot of tumors that can be a lot bigger than people think that I think can be safely treated with radiosurgery. And again, I also think that the people who are going for surgery, I think the surgery nowadays, and more people are thinking this, can be very safe. You can safely do that surgery by taking away a lot of tumor without doing the stuff that's going to hurt the person. Because most of the complications that you see is removing that final 10% of the tumor. It's peeling it off the nerves and the arteries and the brainstem. So again, I think, let me start by saying there are many different ways of treating these. I respect them all. I respect all of my colleagues in different ways of treating them. I think they're all okay, but I do think that there's a trend towards some of the stuff I'm talking about, and each person is different.
We've definitely been hearing that. There's a question about CSF leaks and complications after surgery, and how long you have to worry about that. So there's a patient that had surgery in January of this year, and just is wondering if she still needs to be concerned about a CSF leak, and then also is still having tenderness around the incision site and is wondering if that's normal.
Sure. So the CSF leaks, there are 2 types of places, and CSF leak is, again, only going to occur in an open operation. I mean, you're not going to see that from the radiation or observation. There are 2 types of leaks that you can have. One is, so the CSF is the brain fluid that bathes the brain. And when the operation is done, that fluid is now not contained in the brain. So that one place it can leak out is out the incision itself behind the ear or above the ear. You can have the fluid leak out the incision site. A second place it can leak out is the CSF can leak into the air cells. There are air cells called mastoid air cells that are drilled during the surgery, and they can go in. Usually at surgery, we put bone wax or material to seal off those cells, but it's possible for that fluid to leak out those air cells and actually go through the air cells, through the eustachian tube, and leak out your nose or leak down your throat. So you can see leakage of cerebrospinal fluid either from your nose or the wound after surgery. Now, I would say you're likely to see that, over the first few weeks. I mean, it's possible. I mean, I've seen somebody have a wound, there was a scab, and then the scab opened up months later and the wound opened up, after months. I mean, these are rare. I would say the most likely time that one is going to see a CSF leak, whether it's from the nose or from the skin wound, is likely the first week or 2 or 3 after surgery. I think if your surgery is in January and you're right now, you should not be worried. I would not, if I were you, I would have zero worry about a CSF leak. As far as the tenderness and soreness back there, anytime there's any incision anywhere, I mean, we cut through tiny nerves. So there is a possibility, you know, you cut through little nerves, you can have nerve type pain. I mean, that's true whether we make an incision here, whether you make an incision in your knee or your elbow or anywhere, you can have nerve type pain from cutting through the little nerves that run in the skin or the muscles or anywhere. And that I've seen, you know, I've heard of patients with acoustic neuromas. Sometimes there's a little bit of soreness there. Sometimes they have a lot of soreness, and there are different theories as to whether putting the bone back makes a difference or not. And I'm not really sure about that at all. I think it's a normal thing. It can happen from the surgery. I think things that can help, you know, one is I would start with over-the-counter pain medicines like Tylenols, Advils. Sometimes a heating pad or an ice pack is something that could be considered. If it's really bothersome pain that occurs back there, and sometimes people do have really bothersome pain where the surgical area was, other medicines like gabapentin, Lyrica, or Elavil can be considered. Again, I also mentioned other things like whether it's de-stressing, listening to nice music, you know, sitting in a hot bath, you know, doing your favorite thing, saying, I need a little alone time in my life, somebody else hold the crying baby. I mean, whatever it is, I mean, I think there's a lot of other things that contribute to chronic pain, but I think that is something we do see, and there are a lot of things that might be done that might help with that problem.
Okay. We're getting close to the end of our time, so I think this is probably going to have to be our last question, but is there a downside? So if you're watching and you're waiting and you're kind of on the fence about whether or not you should move forward with treatment, what is the what's the downside to moving forward with stereotactic radiation? And then also, who is the doctor that does Gamma Knife? Is it a neuro ENT or a neurosurgeon, or who is that doctor?
Right. So, I mean, the downside to observing is one, I mean, first, it depends how big your tumor is. I mean, if you have hydrocephalus, you have to have treatment right away, or I mean, so it depends how big the tumor is that we're talking about. But I'm assuming you're talking about smaller tumors. I mean, the issue is the bigger it gets, you know, at some point you reach a threshold where you'd say, you know what, radiosurgery is too much of a risk. 2 is there's a possibility you're going to lose the hearing, and we don't know what the hearing, you know, when you're going to lose your hearing. It could be tomorrow. It could be sudden. It may not be gradual. So if somebody has intact hearing, that to me is the big reason for doing the treatment up front, because we have about a 70% chance of saving your hearing where it is. But that having been said, it's up to you to do what you want to do. As far as who does the treatment, radiosurgery involves a team, or it should. There's a neurosurgeon, or at least generally the way I understand it, there's a neurosurgeon. The way I do it, neurosurgeon, there's a radiation oncologist, there's a physicist, there are also nurses, there's other helpers in the department. I also use an anesthesiologist, so when I'm applying the helmet, I have an anesthesiologist there, so he's there the whole time. You want it, you know, for the helmets, I use local anesthesia too, but you don't have to feel anything. Some people are claustrophobic for the MRI. I'm like, we can knock you out for that. Some people are claustrophobic for the treatment itself. We can knock you out for that. But there's a team. The way, in my opinion, the neurosurgeon should be the captain of the team. I am the captain of my team. And again, I just feel that for acoustic neuromas, and I'm not saying this for all radiation treatment, it's a disease that is understood best, as far as I'm concerned, by me. The radiation doctors don't specialize in benign disease. I mean, their whole training is about cancerous tumors. You know, I'm the one who knows, you know, if we have to operate, how am I going to operate? What are the risks of operating? What are the exact concerns? I'm the one doing lots and lots of Gamma Knife. So for me, being the guy making those decisions, deciding on the dose, deciding how much dose gets to this or that, deciding when to treat, deciding how to treat. And this is true for acoustic neuromas and all the Gamma, you know, I've treated, I mean, overall Gamma Knife, you know, let's say 1,500 patients. I mean, but as far as I'm concerned, the Gamma Knife treatment for acoustic neuromas and radiosurgery in general should be captained by a neurosurgeon, one who not only specializes in the radiosurgery component, but is also capable at open surgery. I mean, I think it's a problem. I mean, I think everything is moving towards minimally invasive treatment, surgical treatments, just so you know. So I think this is a trend in brain surgery, but in general, but I don't feel that minimally invasive treatments are for surgeons who just couldn't make it with a knife. I mean, I love doing open surgery, and I feel I'm very capable and skillful. And the minimally invasive is not for people who don't know what they're doing in a regular operating room. It's for people who are skillful in both, but understand that using advanced technology can make a big difference and improve our outcomes. So again, for acoustic neuromas, it is Michael Brisman's opinion that the neurosurgeon should be the captain of the ship, but should work side by side with the other doctors and the other team members.
Great. Well, Dr. Brisman, this was a really in-depth presentation. It was very useful. We had a lot of great comments from people. So thank you very much for taking the time to talk to us today, to answer questions. I want to thank everybody who's attending. Thank you for joining us for our Giving Tuesday Facebook Live. We hope you'll go to the ANA website and go to anausa.org/giving-Tuesday and take a look at all our volunteer Why We Give stories. We want to thank all of our volunteers who are so vital to everything that we do. And also donate to our fundraiser. We're looking to raise money. We know it's been an awful, crazy year, but it's acoustic neuroma diagnoses continue, and we want to continue to be here for the AN community. So we hope that you can help us out if you're in the position to do so. Thank you again, Dr. Brisman. We really, really appreciate you being here.
Thank you very much. Thank you.